Okay, can I start by thanking the Down Syndrome Research Foundation very much for inviting me here to Vancouver. It's my first time here in Canada and in Vancouver. And if I look a bit spaced out at times, the jet lag is beginning to get to me because it's about 6:30 in the evening, so my body thinks. So I'm here to talk about people with Down syndrome who develop dementia, develop Alzheimer's disease. And first of all, I'm going to apologise because some of the language, the terminology I might use might be slightly different here in British Columbia than I use in England. So I apologise in advance for that. And this is the first of 4 linked talks that I'm going to be giving during the 2 days, trying to build up through the 2 days about what we need to understand and what we need to do to deliver the best possible services for people who develop Alzheimer's disease. So this talk, first of all, is about understanding dementia. And dementia has been my specialist area of expertise since I came to Surrey and Borders Trust in 1990. And the very first person that I ever got referred as a clinical psychologist was a lady called Jenny. And Jenny had lived in a house with 5 other people with Down syndrome all her life on the edge of the hospital, a long-stay hospital. And she'd been moved a couple of months before I arrived into the sick ward, as it was called. And the other people in the home were very concerned because people don't normally come back from the sick ward. And she'd been moved because she'd lost all her skills. And nobody at that time really understood what was happening to Jenny or to other people with Down syndrome similar to her. So they asked me as a clinical psychologist to go in and see what I could do. So I looked in the books, couldn't find anything. Looked on it wasn't the internet then, and talked to some colleagues. They said, well, we don't know. So I thought, okay, let's go back to first principles and let's see what I can find out about Jenny. And Jenny, I went to see her and it was a September day, bright sunshine, and I remember vividly I was wearing a bright blue skirt. So I talked to the staff on the ward and they said to me, oh, well, there's no point you talking to Jenny because she can't do anything. All right. I said, I'm going to talk to her anyway. And I went over and I asked her a name and she told me she was Jenny. I thought, well, that's a good start. And then I thought, what else do I do with her? So I said to her, Jenny, what colour's my skirt? And she went, blue. And I thought, oh, there's more to this lady than meets the eye. But the picture they were giving me was someone who used to be fairly able, who used to be able to do all the activities of daily living, who now could do nothing for herself. She needed feeding, she needed total self-care. So it got me really interested about why somebody could lose all their skills very quickly over time. And I spent the next 7 or 8 months being a detective, trying to figure out what had happened to Jenny. And what was really clear at the end, and I won't tell you the whole story because that could take up the whole hour and a half, is that this was a lady who was suffering from Alzheimer's disease, who had been moved away from everything that was familiar to her, and that was probably precipitated by, in some ways made worse, by the fact that her parents had stopped visiting. Her parents had visited every Saturday for the whole of her life. And through detective work, I discovered that her parents had stopped visiting in January, and the progression really proceeded from the February onwards. I managed to trace her parents with the help of a social worker, and probably against all regulation now, me and the social worker bundled her into the back of the car one day, and I took her back to her parents' house. Now, this is a lady who could barely walk, who couldn't eat, feed herself. When we got to her parents' flat, she ran out the car into their arms and she sat and ate M&Ms, like Skittles, I don't know what you call them over here, M&Ms, with a pincer grip. And again, that taught me so much about understanding about rollback memory, which I'm going to talk to you about later. So working with people with Alzheimer's and Down syndrome for me is very personal because it's about Jenny. What I'm going to try and cover in this session is some of the more mundane stuff around Alzheimer's disease. The more interesting stuff comes later in today, so I hope you'll join me then. But it's important to put this into context. So this session is going to cover prevalence and epidemiology, some of the reasons for decline, what you might see people present as, how you might assess and diagnose, some of the health-related issues, and then I'm going to finish by trying to give you a much better conceptual understanding of what happens to people when they develop Alzheimer's disease. So first of all, Down syndrome. Sorry, I will keep putting the S on because we call it Down syndrome rather than Down syndrome in the UK. So Down syndrome, trisomy 21, you all know that. And this is a really interesting slide that someone gave me a few months ago, which talks about all the different things that are related to having an extra chromosome 21. These are the things that happen when you have what occur on chromosome 21. And so it isn't just about Down syndrome, and it isn't just about Alzheimer's disease. People who have an extra chromosome 21 will have a whole load of other things that may also make them more might make them more at risk of. Particularly, we know things like leukemia in childhood is very common. And I think it's just useful to remember that it isn't just about the Down syndrome. As I said, I first knew about Alzheimer's disease 25 years ago, but actually there was a first report back in 1876, which was a report of a case with autopsy of somebody who had what they thought was Down syndrome and Alzheimer's disease. So it was known about, but somehow it didn't come into common parlance, probably because of the life expectancy issues. And what he said was that many of the 54 that they studied were now dead. Can't pronounce that. Phthisis caused a large majority of these deaths, but in not a few instances, however, death was attributed to nothing more definite than general decay, a sort of precipitated senility. Now, if we'd listened to that all those years ago, maybe we'd have been in a bit better place earlier. And the life expectancy of people with Down syndrome has phenomenally risen over the last century. The average life expectancy in the UK of somebody with Down syndrome in the 1930s was 9 for men and 12 for women. 9 years. Okay? And I'm glad that shocks you, because it's really important to remember that. When we talk with families nowadays about the life expectancy of people with Down syndrome, when we talk to families who perhaps have a 55-year-old or a 60-year-old, we need to remember what those families would have been told when their child was born. And what they would have been told was, don't worry, mum or dad, your child, your daughter or your son has this condition. Probably wasn't called Down syndrome then, probably told that they had a Mongol. Certainly in the UK, that was what the terminology would have been. And they're not going to live to adulthood, and they certainly won't live to any age where we expected them to get Alzheimer's disease. So the top two lines, this is an Australian study. So the top two lines are the general population. The top one is for females, the one below is for males, and the curvy line at the bottom is global estimates for people with Down syndrome. And you can see just the huge strides we've made in the last decade. But what do you think are the two main reasons why people with Down syndrome are living longer? Be a bit more explicit.
Well, let's put it this way. Like even 20 years ago, if you were Down syndrome and you needed like heart surgery,
Excellent.
denied.
Okay, so heart surgery is one thing, and you're right, 20 years ago you'd have been denied it. Second one? No, health issue. What second development has been the saving grace of people, lots of people with Down syndrome? What are people with Down syndrome very prone to? No? Day-to-day things. Chest infections? Yeah? So the development of antibiotics. So heart surgery, antibiotics are probably the two main reasons, apart from the fact that we're all getting healthier and living longer, are probably the two main reasons why people with Down syndrome, the life expectancy has shot up over the last 50 years. So a lot of the work that I'm going to be talking about over the next 2 days comes from the work that I've led in the UK between the British Psychological Society and the Division of and the Royal College of Psychiatrists in trying to produce national guidance on the assessment, diagnosis, interventions and support for people with intellectual disabilities to develop dementia If people want a copy of this, if they leave me there, I'll leave a piece of paper at the front. If you give me your email address, or if you email me, because on the back of the handout you'll have my email address. If you email me, I can send you over a copy electronically. That's not a problem. So how do we assess dementia? Well, DSM-5 currently has just replaced DSM-4 and has renamed dementia as neurocognitive disorders and recognises both minor and major types of degenerative disorder. And I'll just allow you to read that a moment. So what it's saying is that there has to be evidence of a significant decline from people's previous level of performance. And that's really important when we come to talk about people with Down syndrome. And it has to affect one or more of your major cognitive domains, such as attention, executive functioning, memory, perceptual or social cognition. And as you can see, that's strongly related to what we were hearing earlier from Dr. David Stein about the importance of things like memory and executive functioning and learning. We need to have that decline reported by themselves, if possible, or someone who is a knowledgeable informant. And again, you will see when we talk about doing the assessment what that means. And we need to be able to document that decline through some form of standardised assessment. And those deficits need to be so substantial that they interfere with your everyday activities. It may not be for people with Down syndrome things as paying bills, but it's other things that they normally would do as part of their daily life. The deficits aren't due to delirium, so people are with it, sentient, and the deficits aren't explained by another major disorder like depression or schizophrenia. And then you need to try and define subtypes. So this is one of the ways that we try to inform what happens. The other issue is that these deficits need to be there for at least 6 months. Okay? So I think what happens quite often is that for people with Down syndrome, a bit like you heard earlier, they engage in some sort of behaviour, and then I get a phone call. So-and-so hit somebody. Yeah? Do you think it's because they've got dementia? Right, tell me else what's going on in their lives. Oh, no, they're exactly the same. Actually, probably not then. You don't need to refer them. So I think what's happened over the years is that people now know the link between Down syndrome and Alzheimer's disease, and therefore anything that somebody with Down syndrome does that's out of the ordinary gets put down to Down syndrome. So a quick refresher for you, if anyone is new to this, about Alzheimer's disease. So Alzheimer's is the most common form of dementia, about 60% of cases. It's really important when you talk about dementia that people understand that dementia is a collective term for a whole set of illnesses. There isn't actually an illness called dementia. Just like if you think about furniture as a collective term, there isn't actually an item called furniture. So it's really important to remember that. And we think there's probably something between 104 and 110 different forms of dementia that you can diagnose. But the most common form is Alzheimer's disease, and it's about 60% of all cases of dementia are Alzheimer's. And commonly, it's slowly progressive, it's non-reversible, it's characterised by deterioration in both your cognition and your functional abilities, and it affects your mood, your personality, and your behaviour. In fact, the only accurate way of diagnosing Alzheimer's, apart from PET scans, which are hugely expensive, most people don't get hold of, is actually on post-mortem. But there is a recognisable pattern of behaviour, pattern of deterioration that we see, that we recognise as Alzheimer's disease. And it's characterised in the brain by 3 things, a triad. So it's plaques, tangles, and neuronal degeneration. Now, some of you might be old enough to remember, you might don't have it over here, but in the UK, when you used to go to the dentist as a child, they used to give you plaque disclosing tablets. Do they do that over here? And you used to chew them and they made your teeth go purple. Yeah, and you could tell where you hadn't brushed properly, so it was always very embarrassing. Terrible, isn't it? But plaque is, if you think of that analogy of plaque in your teeth, plaque in your brain is doing the same thing. It's being deposited in your brain to stop the synapses and neurons working. And the plaques contain a protein called amyloid. And as you'll see in a minute, amyloid is really important in Alzheimer's disease and Down syndrome. So why is there this link with people who have Down syndrome? Well, as we know, Down syndrome is a genetic disorder. It's caused in the vast majority of cases by pure trisomy 21, so an extra chromosome in all the cells of the person. We know that if you do a post-mortem on anyone over the age of 30 with Down syndrome, there will be those neurological signs in their brain of that triad. So every single person will show the plaques, the tangles and the degeneration, even when they're not showing the clinical symptoms. And few show the clinical symptoms at 30. What we do know is that chromosome 21 holds the amyloid precursor protein gene. So this is the gene that tells the body to lay down amyloid in the brain. So if people with Down syndrome have 3 copies of that gene rather than the 2 that you or I have, then that's probably the reason why people get Alzheimer's earlier and it seems to progress quicker. There's also a gene for having a family history of Alzheimer's, and that's found on a number of genes, but it's also on chromosome 21. So there is some thought that there is a genetic familial link as well for people with Down syndrome. And certainly I've worked in families where somebody's been referred to me with Down syndrome and possible Alzheimer's disease. And when I've talked through the family history, what you see is that grandfather had Alzheimer's disease, father had Alzheimer's disease, now the daughter's got Alzheimer's disease. And in one case, I was working with 2 sisters of the lady with Down syndrome, and they were quite rightly saying, well, what about us? And I'm saying, I can't tell you, but there does seem to be in your family a strong familial genetic link. In this case, same way as in some families, there's a link for heart disease or for other disorders. So it does raise other questions when you begin to do this work, not just for the person that you're working with, but for the whole family system around the person. What we do know, though, is that not everyone with Down syndrome goes on to develop Alzheimer's disease. And we think that your ApoE status, apolylipoprotein status, may be relevant. We each have one of 3 forms of ApoE. We think that if you have form 3, it's neutral. If you have form 2, it protects you. And if you have form 4, it makes you more at risk. And so some of the biomarker studies that are happening across the world now are beginning to look at people's ApoE status alongside their amyloid deposition to see if that's what makes some people with Down syndrome either protected at more risk of developing the disease. Okay. So that's probably the most complicated bit of this morning. So if you've managed to hold on to that, the rest of it should be plain sailing. So let's now look at prevalence rates. So how often does it occur? So in the general population, these are Eurodem rates. This is rates in Europe. The rates are, as you see, about 1% if you're 60 to 65. If you get yourselves to 80 to 85, you've got about 13% risk of developing the disease. And if you get yourself a bit older, it's about 32%. And the reason that the prevalence goes up with age is no. It's purely that there are less people alive, generally. So that's why it looks much higher, because of the percentage of people who die of other things. And the prevalence is higher in the general population in women than men because they live longer. Okay? So that's really, really clear. Now, in people with Down syndrome, there's been a number of longitudinal studies over the year, and this one by V. Prasher, who's a psychiatrist in Birmingham in the UK, was one of the first good longitudinal studies. And what he showed was that about 10% of people between 40 and 49 would develop Alzheimer's, just over a third at 50 to 59, and just over a half at 60 to 69. And he thought the average age of onset was about 54 years, and average duration from diagnosis to death was about 4.5 years. And that's quite an old study. So let me show you some more modern figures. This is from a very large London consortium study, London being where the study was written about, because it actually involves data from us in Surrey, from people in Cornwall and Devon, and from London. And what it shows was the median age of onset was 55.4 years, so not hugely different. 50% of those who developed dementia were diagnosed in their 50s. But what's important to know from that is that 50% weren't. And again, it's really important to recognise that some people develop it later, but some people are developing it much earlier than that. And the mean survival time was about 4.1 years. Again, very similar to what V. Prasher showed 20 years earlier. But what we know now was that the age of diagnosis is highly predictive of your survival time. So the earlier that you develop Alzheimer's disease in this population, the longer you live with the disease. And the later you develop it, on the whole, the shorter you develop it, you live with it. And that's really important new information that we really didn't know previously. What's also really clear from all the research is that gender, sex, is not predictive. There is no studies that I know of that show that women are much more likely to get Alzheimer's than men in Down syndrome because of the age issues. So it's really important it's not just about women, it is equally men and women here. And again, it's quite a nice graph to show the sort of comparison of prevalence rates by age. So the blue line, it's got a thingy, it's working. No. Okay, so the blue line is Down syndrome, people with Down syndrome. The green line is people who have intellectual disabilities without Down syndrome, and the red line is the general population. So what you can see is the curves are the same shape, but the risk is much earlier and much greater for people with Down syndrome. And you will see some people, even as early as below 30, developing Alzheimer's disease. It is rare, but you will see them. And they need particular consideration. We had referred about a year ago a very interesting young man who was 26 when he was referred to us. Very able, does sport for the Special Olympics, works in a pasta restaurant. It's a very full life. And when we assessed him, he seemed really able, but his short-term memory is completely shot to pieces. And when you talk to him, he knows his short-term memory is going. And so that's really interesting, trying to work out what's going on with him at such a young age. So what's our current thinking about the prevalence of dementia in people with Down syndrome? The very latest study that we've looked at is that of McCarran in 2014, and they thought that about 80% of people with Down syndrome will have dementia at the age of 60. And that places a huge burden on the services that we need to have in place ready to support people. We need to be thinking, as we'll talk about this afternoon and tomorrow, we really need to be thinking much earlier about what we do with people, how they live their lives, where they live, what the support mechanisms we need to have in place. This isn't just about the individual. This is about the support systems that society needs to place around people with Down syndrome to give them the full lives they can get. We know that the prevalence is that 2.5 times greater in people with Down syndrome than people who have intellectual disabilities without Down syndrome. We know that the prevalence rates may drop with increasing age. There does seem to be a group of people who, once they get past 60, if they haven't got Alzheimer's then, are probably less likely to get it. So there is a healthy cohort of people who seem never to get the disease. The oldest person in the press that we know lived with Alzheimer's that we can verify was 83. There was in the UK quite a few years ago in the Down syndrome newsletter for the UK, somebody purporting to have a 100th birthday party. We did write and say, can we have some validation of that? We didn't get that. So I'm slightly more sceptical about the 100. But certainly the oldest person in our study, and we've now followed up 500 adults with Down syndrome, died when he was 81, and he had no signs of Alzheimer's disease. So there does seem to be a group who seem to be able to live quite successfully without developing the disease. And Alzheimer's disease is now the leading cause of death in people with Down syndrome. And I think it's really important to recognise that. So you don't die of the Alzheimer's, but it causes your death. Okay? So we really need to pay increasing attention to this disease. Some issues that are beginning to become more salient is this whole idea of brain reserve. Again, I'm not a neurologist, but what we know is that some people have a good passive brain reserve, their brain mass, their size of their brain, the number of synapses, their inherent ability protects them. Some people have a better active reserve, so that they can improve their networks through occupation, through activity. There's slogans in the UK about use it or lose it. And I'm not sure it's probably very similar here. And again, there is some evidence that the more you use your brain, the more you increase its ability. But what we know is that people with learning disabilities, intellectual disabilities, probably don't either have active or passive brain reserve. So they don't have the salient ability to protect themselves. We do know that some of the risk factors are less common in people with Down syndrome. So we know that rarely do people with Down syndrome smoke, and rarely do they have ischemic heart disease. So although they've had congenital heart problems when they were born, that doesn't on the whole tend to lead into ischemic heart problems. So they're much less likely to get a vascular form of dementia than people in the general population. So preventative strategies, well, we haven't got many really at the moment. Use it or lose it, as I say, to try and improve brain reserve. But we know that doesn't happen in all people. If you think about some of the famous people who have developed Alzheimer's disease, who clearly have used every part of their brain, and it still hasn't managed to protect them. We need to try and protect people's hearing and vision, because obviously that helps. Can we do cognitive training? How can we train people's memory, executive function? Is that possible? There's people looking at non-invasive brain stimulation, but again, whether that evidence of that works or not. We know that protecting your heart is important, so eating well, eating wisely, reducing your drinking, reducing your smoking. We know that sleep plays an important role, and especially sleep apnea, and people with Down syndrome are more at risk of sleep apnea. And then probably the thing that actually we need to look at most is how do we reduce the amyloid overproduction in people's brains, because that is what's going to work. But that's going to have to happen for people much, much earlier. That amyloid clearly gets laid down in the brains, maybe as early as in people's teens, in people with Down syndrome. So what can we do? There's lots of research going on internationally, looking at medications, looking at vaccines. But as I said, you need to start this really early. And the ethical dilemmas of trialling medication on young people who perhaps couldn't understand or give consent is really a tricky issue. So when we start to try and think about Alzheimer's disease or dementia in people, generally or people with Down syndrome, we need to understand that there are a whole lot of conditions that can mimic dementia in its early stages. Diagnosis of dementia should always be a diagnosis of last resort. It should never be your first point of call. And I think nowadays, because people do know the connection between Alzheimer's disease and people with Down syndrome, as I said earlier, the minute that somebody with Down syndrome starts to show any differences at all, it immediately gets put down as this person must have dementia. And that's a really, really dangerous place to be, because misdiagnosis can cause people more problems than late diagnosis. So we know that there are a huge number of physical health issues that can give you signs that you might have Alzheimer's disease, particularly things like uncontrolled epilepsy, if your nutrition isn't good, if you've got electrolyte abnormalities, and particularly for people with Down syndrome, if you're hypothyroid. So if your thyroid isn't being checked annually to check you're within the right levels, that may just in itself cause the problems. We actually had a gentleman that was referred a few weeks ago who we'd assessed previously and we reassessed, and he's much better. Don't don't normally recover from dementia, but we hadn't actually diagnosed him, but we were concerned. And what we actually found, he was hypothyroid. So we're actually giving him too much thyroxine to actually control his thyroid, and it was actually making him worse. So that balance is really important for people. We know that a lot of people have, particularly people with Down syndrome, have sensory impairments. So visual impairments, particularly the development of cataracts at a very early age, can result in people looking as if they're lost, if they're not recognising people. And again, people might think, oh, well, they've got dementia, but actually probably fairly simple to work with. And again, the same with hearing impairments. If you're not hearing properly, then you're less likely to understand what people are saying to you. You might repeat the same question over and over again because you've not heard the response. So people might think that's a short-term memory issue rather than what it is as a hearing deficit. And the hearing problems you need to think about two different things. You need to think about both conductive hearing loss, so whether you need hearing aids, but you also need to think about earwax. And earwax is a huge problem for people with Down syndrome. People with Down syndrome physiologically have narrow ear canals. And so they are much more likely to get impacted earwax in their ears. And again, I can certainly think of a number of people we've assessed where we've actually had to say, no, we're not assessing them anymore until you go away and get their ears syringed. And you come back and it's like you've met some totally different person. And then there's a beautiful piece of research that I discovered a couple of years ago, which talks about the importance of your back teeth. And there's a piece of research that says that when you chew, any of us, you chew on your back teeth, that keeps your earwax under control. It helps to break down the earwax. So again, dentistry is really important. How many people with Down syndrome have really poor dental hygiene and end up having teeth out? So if you haven't got your back teeth, and you've got narrow ear canals, you might actually be making your hearing much worse. So very simple solutions to things that you can look at. We know that having mental health problems can actually mimic the sign of dementia, particularly depressive illness, maybe psychotic disorders less common, or even chronic anxiety. So again, we need to make sure that we identify and treat those. One cause of pseudo-dementias that we actually perhaps don't pay as much attention to as we should is this whole idea of too much medication, iatrogenic causes. What we do know is that for a lot of people, not so much people with Down syndrome, but people with other intellectual disabilities, is that a lot of people are taking a huge amount of medication. It's really interesting. We're quite happy to give people antipsychotics, anti-epileptics, benzodiazepines. What we're not very good at, particularly in the UK, and hopefully it's different here in British Columbia, is we're not very good at giving people pain medication. So a lot of research I've done and research other people have done that shows we're happy to fill them up with all sorts of really horrific things, but when you have pain, you're lucky to get 2 paracetamol. Is there paracetamol over here? Right. And if you get 2, you're very likely to not get another 2. So actually, we cycle people through pain a lot of time. So pain is really important, but all these other medications can actually make you look as if you've got dementia. Other conditions, sleep disturbance. So again, we know that people with Down syndrome are much more likely to have sleep apnea or other sleep disturbances. Again, as David Stein was talking about earlier, you might need to do social stories to help them go to a sleep clinic and have the tests they need, but it's really important that they do that. And then we go on through some of the less obvious things that we talk about. So life events. And I think we really underestimate the effect that life events have on people with intellectual disabilities. We may not be able to use the same sort of life events inventories that we would do for you and I, but things like loss of family members, moves, changing day centres, changing school, changing friends, changing key worker can have a really deleterious effect on somebody with an intellectual disability and may make it look as if they've really declined. We've got a gentleman at the moment we've just been assessing. And again, his scores and all the tests are very similar. But what's really clear is that they've gone from a system in the home, from having dedicated key workers to changing the key worker every 3 months. And this gentleman has had a whole series of attachment issues over the years, and he really, really can't cope with the fact that his key worker doesn't seem to be, as he sees it, his friend anymore. And his behaviour and his apparent decline is caused really quite clearly through that change. We also need to think about the impact of poor social and physical environments. So again, those can cause loss of skills and regression. And again, I'll talk a bit about physical environments later today. But the physical environment is often forgotten about how confusing, how disarming it can be to someone with Down syndrome. We also know that some people are abused, unfortunately, either physically, environmentally, psychologically abused, and that can also lead to loss of skills. And then for some people, they also may have an acute organic brain syndrome. So something might lead them to confusional state, secondary to pain or chronic infection or head injury. So as you can see, when we start to talk about thinking about Alzheimer's disease in people with Down syndrome, there's a lot to think about before we even begin to think, has this person got this disease? So how do you know if it's dementia? So for me, we need to check and treat these things that come from that list before. So do people have a thyroid issue? Is your thyroid being tested annually? Again, there's always the issue of people not wanting blood tests. But again, there are fingerprint tests being developed that you can actually use to test thyroid levels. Are people depressed? Have they been treated for their depression either through psychological methods or, if necessary, through medication? Have people got other mental health problems? Sensory problems? Have you had your vision and hearing checked, which should be at least biannually for this group? Are there other physical problems? We know that people with intellectual disabilities, because of their poor communication skills, are much less likely to tell you about physical problems in their body. We know that they're much poorer about knowing which parts of their body even exist under their skin. And so being able to tell you that there's a problem in that part of the body can be very difficult. So we know that things like cancer and serious diseases often get diagnosed very late in the day. Is it around environmental changes or psychological problems, or do they have another neurological condition? So do they actually have a brain tumour or something else going on in their brain? And last but not least, we really must make sure that we look at polypharmacy, the effects of too many medications. And only if all those have been checked and symptoms still exist for more than 6 months would I even begin to think about this possibility of someone having dementia. And that goes against all the things that certainly happening in the UK, which is about swift diagnosis. So in general, the National Dementia Strategy in the UK is about people going to their GP and getting a diagnosis the minute they walk in the door. And that's really dangerous for this group of people, because so often you can get it wrong. And it's really important that we get it right so people live as fulfilling lives as we can manage. Okay, so now I'd just like to do 2 or 3 slides thinking about how it presents in people with Down syndrome. So some of this I've already said, but I think it's worth repeating. So that the most common form of dementia in this group of people is Alzheimer's disease. And as I said, we know that it's almost universally found in later life in the pathology of people's brains. As I said previously, vascular disease, ischemic heart disease, and therefore the risk of vascular dementia is on the whole very rare. So this is one group where it's really clearly primarily Alzheimer's disease. What we do know is that compared to the general population, dementia in people with Down syndrome may present atypically at the beginning before you get the full clinical picture. And I'll show you the next slide first. So everyone, when you ask people what the first signs of dementia is in people generally, people nearly always talk about memory problems and language finding problems. This was a study done by Professor Tony Holland in Cambridge and his group of researchers. If you ever get a chance to see Professor Tony Holland, he is absolutely fantastic. absolutely mesmeric. And what he did is he talked to supporters and families of people with Down syndrome in their early 30s and said, what was the first sign that you thought that something different was happening to the person? And what he thought they would say was the memory and the language. And what they just said is no. It was changes in mood, it was changes in behaviour, it was changes in personality, in people's social skills, and more importantly, changes in executive functioning. So all those things that you heard about this morning from David Stein, about planning, about initiation, about problem solving and reasoning. And again, very clearly, again with what Dr. Stein said this morning, is that people with Down syndrome tend to have smaller frontal lobes. And therefore, once the amyloid starts getting deposited in people's brains, because the frontal lobes are smaller, they get affected first. So as the amyloid gets deposited in your brain, because the frontal lobes don't have so much capacity, it affects those functions first. And again, quite often you'll see people in the early and late 20s with Down syndrome who seem to have lost, some of my families tell me, they've lost their oomph. They've lost their ability to start things. So they'll talk about people who left school, who were really active, who had joined in all sorts of things, and now it's real difficulty just getting them to initiate, just getting them to start and get off the sofa and start to join in activities anymore. And again, we're not clear yet because we've not followed them up long enough, but whether that is a precursor for those people going on to develop Alzheimer's disease, perhaps younger than other people might. So it's really important that we understand that executive function and therefore assessing executive function is really important. The other major difference in this group of people that we see is that dementia in people with Down syndrome may be associated with the onset of epilepsy and seizures for the first time in their life. And the studies that have been done looking about the onset of epilepsy shows that between 78 and 98% of people with Down syndrome who develop Alzheimer's disease also develop epilepsy for the first time. And again, that's really important for families to understand and staff who support people, because the first time that happens, the first time they have a seizure, can be really quite frightening for people. Often they get taken by ambulance to the local hospital, they see a junior doctor who's never seen somebody with Down syndrome, never mind somebody with Down syndrome and Alzheimer's disease, and they really don't understand that the epilepsy is part of that progress. So it's really important that we start to educate people who support people with Down syndrome about the risk. What we do know is that the middle and later courses of Alzheimer's disease are similar to those experienced by people in the general population, so not much difference. It is the same disease. We're not looking at something different. But the time course has been reported to be more rapid than general population, as we saw from the earlier slides. So that probably takes up the majority of people with Down syndrome. What we do know, though, is that there is a very small group of people with Down syndrome who seem to have an atypical presentation of Alzheimer's disease, or atypical presentation of something. So there are anecdotal reports in the literature, and when I talk to other people who run big cohort series, we've all got 2 or 3 people in our groups who in their teens or early adulthood deteriorate, often very, very rapidly, and then plateau, often after a life event, and never recover. So they don't seem to then go on and develop full-blown Alzheimer's disease in the way that we see it, but they've lost all their skills. So it might resemble dementia, might resemble depression, but nothing you do seems to either make it worse or resolve it. It's really unclear how such problems should be best conceptualized. There was an article written a couple of years ago that talked about it being like OCD. And I couldn't get my head around seeing it as an obsessive-compulsive disorder, because it doesn't feel like that. It just feels like these people are just sort of almost stuck. And you can see often in the people who deteriorate like this, the signs of ageing. So I can think of a lady many years ago that got referred to me who had been very able. She'd worked in a laundry, she'd lived on her own, really, really capable young lady, and who literally seemed to deteriorate over a period of months, plateaued off, but also looked old. So she got the hair loss and the signs in her skin and her face of the ageing that you would see, but literally over a period of 6 months. Plateaued, didn't change. So again, it's a conundrum, but an interesting conundrum, because these are some of the people that we need to look at much more closely. And we need to try and think about how we progressively, if we can, help people back to any semblance of their previous functioning. Okay, so what we've learned so far, I hope, today is a bit about the prevalence and epidemiology of people with Down syndrome. So what I'd like to do now is think a bit more about assessment in adults with Down syndrome and the importance of doing thorough assessments. So, first of all, these are the sorts of assessments that we'd need to think about when we're talking about people with adults with Down syndrome. And let me go into those in a bit more detail. Before I do that, just to say that remember that this is a progressive disease. And so what we see in early stage will then progress to different things as the disease progresses. And again, it's really important that we begin to think about each person and what they might be able to do at early stage, through to middle stage, through to late stage. So you can see from this slide how things progress in each of those 4 main areas of memory, language, perception and executive function, and how it affects their day-to-day abilities. So our assessments are gauged at trying to work out what's happening to people and where in the progression they are, because it helps us think about what we might need to do. One of the difficulties when we're trying to assess somebody with an intellectual disability, whether it's Down syndrome or any other form of intellectual disability, is that we can't use norm-based tests. People with intellectual disabilities are not a homogeneous group, as people think they are. And therefore, we can't use the sort of assessment tools that we use in the general population, because everyone will have their own set of intellectual problems. What we know is that a core feature of dementia is the decline from a baseline level of the person's functioning. And it's really important that we know what those pre-morbid skills are like. And it's often very difficult to do that within the population of people with Down syndrome or in intellectual disabilities. As I said before, there's a variance in people's cognitive functioning and abilities. We have some people with Down syndrome who are very high functioning, very able, and we have some people who are much more disabled by their disease. There's often frequent poor record keeping from childhood, particularly for people who are adults now. So when we're looking at people who might be 55 now with no known relatives alive, trying to find out what they were good at when they were little is really quite difficult. Staff change frequently in services, record keeping is poor. And there might be lack of consistent involvement of a family member or staff throughout the person's lifespan. So we haven't got good informants who can tell us about what this person was like much younger in their lives. We know that the early signs of dementia, as we've talked about, can be subtle and require really careful observation to identify concerns in a timely way. And I think what happens is that people who are involved with the person on a day-to-day basis get used to the changes so that they don't see that the person is changing. And it's often only when perhaps a family member who hasn't visited for a long time, or recently we've had it with a member of staff who went away for 3 weeks holiday and came back and went, oh my God, they've really changed. Because as you see them day to day, you just think, oh, that's Fred or that's Ethel or whoever. So it's really important that we think about what's happened to people previously, what they're like. One of the things I always suggest that people do is video people where possible. So often if people in day services or in homes will have taken videos of parties or holidays or outings. And actually going back and watching some of those really early videos can really tell you about the changes in people's abilities over time. And can really quite shock people when they look back and go, oh my God, could they really do that? I'd forgotten how able they were in the past. And it's a really important part of the learning. So the assessment process. I think there probably are 5 stages to the assessment process, which I'll take you through now. The first one is about history and information gathering. So it's about taking time to actually talk and think about the nature of what's going on for the person. So how long has this been going on? What's the rate or pattern of the change? Is it sudden or is it gradual? If someone wakes up tomorrow morning and has lost their skills overnight, that is not Alzheimer's disease. Something catastrophic has happened in their brain overnight that needs dealing with in a very, very highly skilled emergency way. But it is interesting how people don't think to do that. So again, you need to think about that. Are there any other conditions, such as seizures, or any other health conditions that you can know about, that you can talk about? What's been the impact on the person's overall abilities and personality? So tell us more. Just give me a story. Give me some examples. Tell me about what's going on. Then you need a really good history of people's significant physical and medical history. And again, what past and present medical conditions they've had. And again, it's really important that those are really clearly itemised in people's records, because again, as staff change, that history gets lost. So I had a gentleman who we thought probably did have Alzheimer's disease, who suddenly developed chronic and acute and chronic diarrhea. So he had diarrhea 4, 5, 6 times a day. It was literally running down his legs at times. And people were going, it's dementia. And I'm going, no. Sorry, this isn't dementia. You don't get that sort of chronic diarrhea and acute diarrhea from dementia. Let me go back. Let's look at his records. And it took a while to really go back through, files this thick of his notes. And what it turned out to be was that he used to have Crohn's disease. And he had a flare-up of his Crohn's disease. But nobody knew in the home who currently supported him that that was part of his medical history. And once we got that sorted out, it took a while. The hospital were not playing ball about reasonable adjustments, but that's another story. But once we got his Crohn's disease sorted out, then actually his life turned around again, because it meant he could go back to his day activities, he could go back to going out and socialising with his friends without that fear and embarrassment of having diarrhea. And his whole personality changed. So it's really important we know people's history. We need all to know their mental health as well, whether they've suffered from depression or anxiety or other mental health problems. We need to know something about their developmental history and what were they were really good at their best. So how do we know what they were like at their peak of their ability, and so that we can compare what's going on? So is there any previous data? Is there any previous records? Any records of history? Any records of interest? Anything that we can find to develop a picture of this person? We want to know people's family history. So again, I want to know what's happening in their immediate relatives. And so again, think about what that might be. And then trying to think about psychosocial issues. So things like house moves, decline or death of other people that they like or love, changes in people who look after them, changes or retirement from their work or from their day service, anything that's happened in their life could be making them be different. And that should be about gathering information from informants who really know the people well and who really know the person directly. So we'll always follow up with somebody in their home, somebody in their day service, and speak to family members, even if they only see them infrequently, to try and get a picture of what's going on. Because we know that people with Down syndrome in particular can be very different in different environments. They learn to behave very differently for different people. And so again, we'd want to know the picture of how they are in different places. Then we would refer them to our psychiatrist for a mental state examination. So we'd look at alertness, their orientation, and all the sorts of things that psychiatrists do. And then we would look at evaluating their memory and cognitive functions via formal assessment. We'd also refer them to their general practitioner, doctor, medical practitioner in the UK, to actually have a thorough, complete physical examination. So we'd want to look at their cardiovascular system, any neurological problems, hormones, signs of hypothyroidism, and any effects of new or old medications. It's interesting just how many medications people have been on for all their lives, and people can't even remember why they're on them now, but actually just add more on. It seems to be very good to add more on, but never to take stuff away. And then wherever possible, we want to do some basic brief physical checks like blood pressure, if people allow you, pulse, looking at pain in particular. And we use health checks in the UK. So people with intellectual disabilities should now be getting annual health checks, physical health checks. Don't know if that happens here in British Columbia.
There are healthcare guidelines, but they're not always followed.
Yeah, I mean, they're not always followed in the UK, but the Department of Health and NHS England say that people with intellectual disabilities from the age of 14 should always have an annual physical health check. The quality of those does vary across different services. And there's some of the physical examinations that we would ask the GP to look at, with optional other things where necessary. Neuroimaging. I've left it blank because I'm not a neuroimager. There's a lot of controversy about whether you should use neuroimaging or not. It's really difficult. If you think, I suppose the position that we take in the UK on the whole is if you think this is purely Alzheimer's disease, there probably isn't a lot of benefit of going down the neuroimaging road at the moment. Getting consent is always an issue. Getting compliance is even bigger an issue. There was one study by V. Prasher about 5 years ago looking at a trial of neuroimaging with people with Down syndrome, which he had to abandon. So about a third of his people were able to have an MRI scan without sedation safely. About a third of people had a scan with sedation, and then 2 people went into respiratory arrest in the scanner under sedation, and he stopped the trial. So what we advise in our service and in local services is caution. If you think the pattern of what you're seeing looks typically Alzheimer's disease, there probably is no advantage of doing an MRI or a CT scan. If, however, you've got an atypical pattern and you're not sure what's going on and you might think there's something else compromising their brain, then obviously you'd need to do a thorough risk assessment to look at the risks and benefits before deciding whether to proceed, particularly if you are going to have to use sedation. And that includes working very closely with your radiology department to help them understand the risks. PET scans are not available in that way in the UK at the moment, only as part of research projects. Don't have PET scans, or privately, and very few people with intellectual disabilities would have funding to do that. We then want to assess people's environmental lives, the assessment of their social and physical environment. So we'd want to look at the quality of people's physical environment. We'd want to look at staffing levels, day and night. Again, is people just changing because there aren't sufficient staff around to support people as they get older? We'd want to look at the mix of people in the settings. So is it this that they're not getting on with somebody? Has somebody new been moved in, either to their home or to their day centre, that's upsetting them? What's the quality and the quantity of their day activities? We've had some people being referred for dementia who've had such a busy day activities programme, it would make me absolutely exhausted, never mind anybody with an intellectual disability. And you say, actually, you know, this person's getting older now. Do you think they really need to be out 9 to 5 and every evening? They need some time to be at home and just sit and do. Or some people who are just bored witness by their day services or their day activities and actually need a programme of stimulation. What are the characteristics of the staff that are supporting them? What are their attitudes? What is their competence and understanding the needs of people with intellectual disabilities as they go older? What's the consistency of approach? And consistency is going to be a theme that I try and develop this afternoon. It's so important. Are people doing different things with people, so making them confused all the time? And a review and a scrutiny of both their historic and their current support package. So what actually are we paying for? What actually are they getting in that support package? Is it effective in meeting their needs? And then we come to the thorny issue, okay, you want to do some sort of neuropsychological evaluation of that person. What are the appropriate assessment tools that you need to use? And this is really a key issue because the assessment tools that have been developed in the general population are not appropriate for people with intellectual disabilities. And certainly within the UK, but certainly if you look at the literature internationally, there is no agreed battery of assessments to use to actually look at screening for this population. And there continues to be a paucity of research data to actually secure agreement on what would be best. And so certainly in London, we're trying to pull data as much as we can to try and work out what are the best assessment tools. But what's really clear is that each individual needs to be viewed independently in terms of their own functioning. So you have to have some sort of baseline assessment when people are well at the peak of their ability on record so that you can compare it to at a future date. And that is quite a strain on resources to do that, particularly if you've got a large population of people with Down syndrome. So what would be the minimum that I would expect people to do? So I would expect people to be using some sort of validated instrument for looking at cognitive abilities of people with intellectual disabilities. There are a number of them around. The one I use is the NAID, the Neuropsychological Assessment for Adults with Intellectual Disability. It's quite short, it takes about 45 minutes. It has good depth, which is important because you want to be able to see change over time. It has good floor and ceiling effects, so most people score on it within the range. People with very severe intellectual disabilities might not get off the floor, but most people manage to score within the range of the test. You also want to look at short and long-term memory, both visual and verbal. I'll come back to executive function in a minute. You want to look at all people's orientation skills. You want to look at their language, both expressive and receptive. And you want to be able to record evidence of new learning. And then the bit that we've just added on recently is trying to find tests that really can look at people's executive function. And that's really difficult because a lot of the tests that are out there haven't been adapted for the needs of people with intellectual disabilities. So what we know is that it's increasingly important to assess executive function. There's no agreement on what tests to try, but several under development. You can use bits of tests, but again, it's really important to think about which ones you're using. And some informant scales may be useful, but we're not sure. We're working on using two tests that we're developing. So the BADS is the Behavioural Assessment of Dysexecutive Function. In our service in the UK, we've been developing an adaptive version for people with intellectual disabilities. It has a number of elements, but two in particular we've been trialling with people with Down syndrome. One is the simplified key search. So you have some pictures that say that this person has lost his keys. You can see his pockets are empty. And here's the field where he's lost the keys in. And you have to say give him a pen and say, plot your route round the field to try and work out where your keys are. And you score depending on where they work out, so what system they use for scoring. But as you can see, that takes quite a lot of verbal ability to understand the instructions. So it's quite a high verbal load to understand that. And the second one we use is the supermarket map. In the version of the BADS for people in the general population, they use a zoo map. We decided that was too complicated and perhaps zoos weren't the place that most people with intellectual disabilities have any experience of on a day-to-day basis. So we've changed it into a supermarket map. So there are two versions. You give people a map of the supermarket, it's very simplified, and you say to people, I want you to find these things and get to the till. And then the second version, you say you've got to find them in the right order. So again, you're looking at people's planning skills, but again, quite a high verbal load to be able to explain the test for people. What we are more excited about is this new measure called the Measure of Everyday Planning. It comprises of a grid of related but independent areas of functioning. So it looks at 4 areas: initiation, planning and sequencing, memory, and attention and concentration. And what we've done is produced a grid that looks like this. You probably can't read at the back, but if anyone's interested, you can contact me. So this is the simplest grid. You're at home and you feel thirsty. What do you do? So initiation ranges from do nothing to gets up and goes to a suitable area and starts making a drink. Planning, not able to plan, through to being able to plan even when there's a problem. Memory, can't remember, they're feeling thirsty long enough to take any action, through to being able to remember all the steps in a task even when there's a problem. And attention concentration, makes no attempt to get a drink and is able to make a drink despite major distractions. So you can see how you can actually plot through, either through observation or through an informant, what people's pattern might be in actually doing some simple tasks. We've developed 4 of these grids. This is the most simple, they go up in difficulty. But what we've also done, have I got it here? Yeah, is actually produced a blank grid, so you can actually make your own grids. And so what we're suggesting and what we're trialling in the UK is that we do the 2 easy grids with everybody, and then you choose something that the person really likes and does really well at baseline. So they might have a preferred activity or a really special interest in something. And then if you repeat the grids longitudinally over time, you might be able to pick up that changes in the executive function and see which areas are changing first. So that's quite exciting to be able to think we might be able to pick up in a fairly structured way changes in people's executive functioning from the beginning. We also do, as I said before, we do informant interviews. So we always see somebody who knows them well in their home and in their wherever they go during the day. So look at things like short and long-term memory, general mental functioning, things like dyspraxia, dysphasia, daily living skills, personality and behaviour. Again, there are different tools that you can use to look at those, or you can actually just use an informant interview process. There are other measures looking at psychological or mental health that you might want to use. Carer burden might be important, life events, and particularly adaptive functionings. And the important thing when you're looking at adaptive functioning isn't just about the change in quantitative scores, but the qualitative scores. So somebody might still be able to dress themselves, but how they do it is differently, or how long they take is differently, or the order they do things is different. So you're looking for not just a change in score, but a change in how people are attempting tasks. And that's really important. And that's the skill of the interviewer when they're talking to the informants about trying to elicit the changes that's going on and noting those. It's important that we try and explain those assessments to people with intellectual disabilities. So we need to try and get their consent if possible. So we need to use different communication methods, particularly the use of picture booklets. We need to relate those to people's prior understanding of the issues and not to try and cause people anxiety. So wherever possible, particularly when I'm doing a baseline assessment, I'll talk about wanting to have on record what you're good at now, so that if there are any changes in the future, I've got something to compare it to. And most people are happy to accept that that's what you're there to do. So it's important to emphasise that what you're going to do and the support available. And where people don't have capacity, where you've assessed capacity and they don't have capacity, then certainly in the UK, we need to use a best interest process to actually gain agreement from other people that those assessments should proceed. Then sharing the diagnosis, and that's often a complex issue. So just like anyone else, people with intellectual disabilities need to be talked about whether they want to know the diagnosis and how they might understand what's going on. If they've already got dementia, then it's really difficult to explain what dementia is, because by definition, they'll have a short-term memory problem. So it's really important that we do lots of work about healthy ageing and what ageing brings before people even begin the onset of the disease, so that those areas of knowledge are in people's long-term memory so you can refer back to them. It's important to use people's own words. So often people with Down syndrome, if they're older, don't even know they've got Down syndrome. People certainly don't know the word dementia. So trying to use those words to describe what's going on is quite difficult. I've certainly had people talk to me about, I can't remember things very well, or my brain doesn't work too well anymore. And if that's how they accept what the change is, that's fine. Don't think you need to go into huge detail. Persons, peers and friends are also important. And again, I'll talk about that tomorrow, I think. They may need people with intellectual disabilities, their families, their caregivers, may need psychological interventions to help them feel emotionally supported and be able to cope with the diagnosis. So it's really important to think in the whole system approach when you're thinking about assessing and diagnosing dementia. When you are breaking the bad news to the person, then the generic breaking bad news models don't fit well with people with intellectual disabilities. We need to communicate information over a period of time and in chunks. They're not going to understand great lots of information right at the start. We need to use a person-centered approach. We want them to be involved as much as possible in all those decisions about their support and care, including what happens to them in the future. So we'd work particularly with our speech and language therapists about using adaptive communication skills. And there are specific resources out there, booklets, about trying to help people understand. And again, I'll talk about more of those later today. So I want to finish. So I've given a lot to you about the medical side of dementia. I've given you a lot about assessing people with dementia. But what I don't think I've given you yet, and I don't think most staff ever get, is a really good conceptual understanding of what it feels like for the person to have dementia. And that's what I want to do in this last 10 minutes. This little book called The Simplicity of Dementia by Hugh Buijsen, I don't know how you pronounce his name, he's a Dutch psychologist. He calls himself a psychogerontologist, and his father had Alzheimer's disease. And he says that actually Alzheimer's disease is a really simple disease to understand if you understand the two laws. And I'm going to take you through those now. So the first one is the law of disturbed encoding. So what this says is the person is no longer able to successfully transfer information from their short-term memory and put it in their long-term memory. So that basically means that once the Alzheimer's starts, the person is unlikely to remember things that have just happened to them. Okay? So if I asked you all to remember a phone number now, and I said you can't write it down and you can't put it straight in your cell phone, apart from panicking, what would you do? You try to figure out. So what strategies might you use? Chunk it. So you might break it into bits and chunk it. What else might you do? Repetition. So you might say it over and over again. That's got a posh title. That's called cognitive rehearsal. What other things could you do? That's cheating. You might try and associate it with colour or with visual things. What are you trying to do by using any of those strategies? Put it in which part of your memory? Long-term memory. Okay? Our short-term memories only last between 20 and 30 seconds. If you haven't encoded it within your long-term memory in 20 to 30 seconds, what happens to it? It's gone. You know, so you go out and ask for directions. We went out and asked for directions how to find the hop-on, hop-off bus, and it's at the hotel. Oh my God, no, stop that. Gone. Okay? Now, what is the consequences if we can't move information from our short-term memory to our long-term memory? So these are the things that happen to us if we can't do that. So we get disorientated in an unfamiliar environment. And that's probably the one that people don't think of most. So if I take somebody with Alzheimer's disease, early Alzheimer's disease, so all these things are happening long before everyone's ever got a diagnosis. So you work with someone with Down syndrome who suddenly says, we've got a new restaurant to take them to, and they go, no. And you go, oh, he's being difficult again. Stubborn is what I hear. He's just being stubborn. But it may not, he's just being stubborn. It may just mean that the anxiety of going to somewhere that's completely strange, where you don't know where you're going, you don't understand what you're going to do when you get there, is really, really severe. You say to people, let's go to wherever they normally go to. Oh, yeah. Because it's in their long-term memory, they know what to expect. That's often when people start to talk to me about people who they think are changing. They say those things inadvertently to me without realizing that that just rings a huge bell in my head. People get disoriented in time. They ask the same question repeatedly, not to wind you up, as staff forever tell me, but because they can't remember they've asked the question. And if they've managed to remember to ask the question, they certainly can't remember what the reply was, because they haven't encoded it from their short-term memory into their long-term memory. They lose track of conversation, because to have a conversation, you need to be able to move information. You need to remember that information the person has just said. So when people suddenly start to walk off or they get bored, it might not just be because they're bored. It might be because they're not encoding. And that means they're less able to learn anything new. We heard this morning from Dr. Stein the importance of repetition in learning something new. But if you're never encoding anymore, you're not able to learn new skills. People lose their belongings, not because they're being difficult, because they put them down in unfamiliar places, and then they can't remember, really can't remember where they put them. So the importance of having particular places for your belongings is really important. They're less likely to recall people they've recently met. So again, staff go, well, he's really rude. Doesn't remember my name. Well, no, he hasn't been able to. He might have some memory of you, but remembering your name in particular becomes difficult. They forget where they're meant to be, and they express anxiety. They experience anxiety and stress. And I think we hugely underestimate how anxiety-provoking, how stressful it is at this early stage of Alzheimer's disease to try and compensate, to try and hide all that's going on in people's brains. Does that make sense? Okay. Second law, the law of rollback memory. Your long-term memory contains all the memories you've ever acquired from your most recent memories working back towards childhood memories. So when you develop dementia, at the first stage of dementia, mid-early stage, you're not forming any new really good long-term memories because of the problem of encoding, but all your long-term memories that were there are fine, okay? But as the dementia progresses, as you get to middle stage, the Alzheimer's disease starts to attack your long-term memory. And it attacks the newest long-term memories first. So in the book, he talks about it being like diaries on a shelf. So on the right-hand side, right-hand side is your newest long-term memories. And this left-hand side is the long-term ones. And as those memories come off the shelf, as those diaries, those books, it's like that never happened. Okay? The other analogy I like to use is like one of those domino games where you line up all the dominoes. So again, this is your most recent long-term memory. At the end of the domino game is your oldest long-term memory. Once the Alzheimer's starts, they're all intact, all through early stage. But as it gets to mid-stage, it starts to attack this first domino, this first long-term memory, and it acts as a cascade. Once you hit that first domino, it starts a process that at the moment we cannot stop. Okay? So what are the consequences of rollback memory? Well, they're all the things that we describe when we talk about Alzheimer's disease, aren't they? So the loss of memory, the loss of social events, the loss of vocabulary, the inability to recognize people. But what's probably most important in this world is the loss of daily skills. Unfortunately, we live in a society that wants us to be using more and more complex interactions, more and more complex appliances. Things change every week, the iPhone 5, the iPhone 6, the whatever you want. It's difficult for any of us to learn all those new things. But how much more difficult is it for somebody with Down syndrome or anybody with dementia who not only can't learn now because of problems of encoding, but is actually going backwards in time? And if you take something as simple as drying your hands, look at how we've progressed over the years. Rarely do you find, except in your own home, something as simple as a towel. We had roller towels, paper towels, hand dryers, and I don't know if you have them over here, but we certainly have the Dyson. The Dyson. I'll just tell you a quick story. I've got a couple of minutes. I first met the Dyson in the toilet at my local hospital. I'd taken my daughter, she must have been in her teens then, she'd done something disastrous as she usually did, and I got into the loo, and I'd been to the loo, and I'd washed my hands, and I looked round for the hand dryer. And I saw this, and I thought, what on earth is that? And I read it said, introducing the new Dyson Airblade. Right, okay, that doesn't tell me anything more. And then the little thing, it said, insert hand slowly and remove. They don't come off. So I did what I normally do, and I used my skirt. And then I thought about it, and it really worried me, because I thought, this is a local hospital. What percentage of people in that local hospital come there would have dementia? Would be very high. If you went into that loo and your long-term, your procedural memory is saying, right, you've been to the loo, Karen, you've washed your hands, now dry your hands, and you can't find anything there that is familiar, that makes sense, that is predictable, how distraught would you be? So if you then started to scream or to shout or to cry or to become agitated or become confused, how easy is that to happen? Purely because they've introduced something that is totally unrecognisable to you in your long-term memory. And that really, for me, is a really good lesson in life. People begin to have flashbacks and see people from their past. So often people say they're hallucinating. I think hallucinations happen a lot less than we think in dementia. I think we don't know enough about people's pasts. So when they talk to us about things, we must think that they're hallucinating. People can't tell you what they had for dinner, but they can talk very clearly about things that happened 30, 40 years ago as if it was yesterday. Because to them, it is yesterday. It's where their newest memories still are now that all the others have disappeared. And people believe they're younger and that time has actually rolled back. So when they look in the mirror, what do they see? That can't possibly be me, thank God. That must be my mum in my case, because I look very much like her. But I can't be that age because I'm not that old. So I hope what I've done so far today is tried to set the scene for you, to try and give you a really good understanding of what happens when people have dementia, what we need to do when we're trying to assess whether someone's got dementia, and to really leave you with a really good conceptual understanding of dementia, which my other talks will hang from, to get you to think about then, how do we support people to meet their needs. Thank you very much for listening to me.